So I'll try to shed some light on dengue illness, and we'll go through the doubts if at all there are any. So dengue illness, it has started like way back in 18th and 19th century, just if you go through the history. However, initially it was thought to be not a major illness, but in 1950 things have changed, and people have started to die, mainly because of its complications like bleeding problems and shock. In India, it has only started in 1980, but if you can see the map, like it has been prevalent all throughout the India. Sorry. It's mainly prevalent in Asia and African countries. Okay, so this dengue, it is transmitted by a mosquito bite. The mosquito that vector is Aedes aegypti. So what happens is that a mosquito bites on a man or a patient who is infected with dengue. It sucks the blood. Usually the peak time is in morning 2 to 3 hours after the daybreak or in the afternoon. Once the blood is sucked in, the dengue serotype provides lifelong immunity to that virus, but however there are other viruses it does not provide cross immunity. So this virus that has sucked into the blood from an infected patient goes on to bite a healthy patient, and the healthy patient will get dengue symptoms 4 to 13 days later on. So the incubation period is around 14 to 13 days. So a person living in an endemic area where dengue is prevalent, uh, an average, the person can be exposed to 3 to 4 serotypes during their lifetime. The common viral serotypes that cause dengue are 1, 2, 3, and 4. So clinical course, like there are three phases that dengue has: febrile phase, critical phase, and recovery phase. So in a febrile phase, the temperature goes up, and then around critical phase, the temperature comes down. However, the complications are more common during the critical phase, like shock, bleeding, organ involvement. And then if the patient survives the critical phase, then they go on to a recovery phase. So from a laboratory point of view, if you see, the hematocrit starts to rise and become and is at its peak during the critical phase and starts to come down during the recovery phase. Platelets also, there will be a drop in platelet count during the critical phase, and when the patient is recovering, the platelets do go up. From the serology point of view, during the febrile phase, um, the antibodies for dengue virus are would be low, so there is no point in doing dengue IgM or IgG during the febrile phase. However, during the critical phase, the antibodies start to rise and they peak during recovery phase. So any child who has a fever of more than 5 days or 1 week, at that time you might be able to detect IgM or IgG antibodies for dengue. However, if you do the antibodies on day 1 or day 2 of life, you will get it as negative. So you need to keep that in mind when you are requesting for the results, because a negative per se of dengue antibodies on day 1 or day 2 illness doesn't rule out dengue. So, looking into the pathophysiology, the main thing that happens in dengue is a vascular leak. So, there is a temporary increase in vascular permeability, and the plasma leaks into the interstitium. So, there is a fluid leakage which mainly collects in serous cavities like peritoneum, pleura, and pericardium. And because of the leakage, there is a hemoconcentration, and subsequently that itself causes hypovolemia. If patient survives the critical phase, during the recovery phase, there is this vascular permeability resolves spontaneously. So mechanism of leak, so when a virus bites it, uh, so the monocytes get inflamed. So the main pathophysiology is that the dengue NS1 specific antibodies, they disrupt the vascular endothelial dysfunction. So they cause a breakage in the endothelial dysfunction, which causes them to have the vascular leakage. So after the mosquito bite, the NS1 specific antibodies would be starting to rise. So So you need to test in the first few days of NS1 protein, which binds to the endothelial cells and it causes the dysfunction. So it breaks the barrier of endothelium, which in turn causes them to have the vascular leakage problems. So pathogenesis wise, there are two infections. One is a primary dengue, where an infant gets a primary dengue infection. And then the secondary dengue infection, which can happen at any age. So a patient can get infected again after the primary dengue. So in this pathogenesis, there is a pre-existence of non-neutralizing bodies. Dengue antibodies can go through transplacental passage from the mother to the child, or they can have antibodies from previous infection. So this NS1 protein, when you test it, it's a higher level in patients who have complications like dengue hemorrhagic fever than patients with dengue fever. So the higher the level, the patients are more likely to have complications. Not necessarily, but the levels would be higher in dengue hemorrhagic fever. So again, going through the pathogenesis, it's a T cell mediated immunity. So when with the infection, the monocytes and the T cells are activated. So that causes them to have secretion of vasoactive cytokinases, tumor necrosis factor, interleukin 2, interleukin gamma. So that breaks the barrier of the endothelium and that causes the plasma leakage. So classification wise, initially the World Health Organization in 1997 has classified dengue into three types: dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. Later on, they reclassified in 2009, saying that dengue into three types again. One is dengue without warning signs, one is dengue with warning signs, and the other is severe dengue. So I'll just go through briefly about the 1997 classification of the symptoms, and then I'll go into the WHO classification. So dengue fever, it's acute febrile illness, defined as fever with two or more of the following. So they can have headache. Older children might complain of retroorbital pain or ocular pain. They might complain of myalgia or bone pain, arthralgia, joint pains, rash. Rash would be erythematous, small maculopapular rash, more like a measles kind of a rash. And some patients can present with hemorrhagic manifestations like petechiae, purpura, ecchymosis. They might have minor bleeding like epistaxis, nose bleeding, gum bleeding. They might have vomiting in the blood, urine or stool, or vaginal bleeding, and leukopenia. Leukopenia is the low white cell count. In dengue hemorrhagic fever, they'll have increased vascular permeability. So the hemoconcentration would be more than 20%. So if a patient has a HCT more than 20% above the baseline, you need to suspect dengue. They can have other complications from the plasma leakage like pleural effusion, ascites, and they can have fever, low platelet count, and hemorrhagic manifestations. So dengue hemorrhagic fever is usually biphasic. The fever lasts 2 to 7 days. The hemorrhagic tendencies can be seen by one of the following: a positive tourniquet test, which I will go through later on. Petechiae are small non-blanching spots that are present under the skin. Ecchymosis or purpura, again they would be under the skin, non-blanchable. Bleeding from mucosa, GI tract, like vomiting blood, and patients might have prolonged bleeding from the injection sites or hematemesis or melena. Thrombocytopenia less than 100,000 per millimeter square cube. So there might be evidence of plasma leakage. So a rise in hematocrit greater than 20% above average for age and sex or population, or a drop in hematocrit following volume replacement equal to or greater than 20% of baseline is the criteria to diagnose the patient as dengue hemorrhagic fever. There might be signs of plasma leakage, like they can have pleural effusion, ascites, and hypoproteinemia. So if patient has further complications like dengue shock syndrome, so they need to meet all 4 criteria of dengue hemorrhagic fever, plus they will have evidence of shock like a rapid and weak pulse. There will be narrow pulse pressure, less than 20 mm, and it can be manifested by hypotension for age, and they can have cold, clammy skin and restlessness. The narrow pulse pressure is the difference between the diastolic and the systolic blood pressure. So this was the whole classification, and again it was reclassified by WHO into three types: dengue without warning signs, where patient will complain of nausea, vomiting, rash, headache, eye pain, muscle pain, joint pain. There will be low white cells on the WBC or CPP count, and they will have positive tourniquet test. With warning signs, they will have symptoms of plasma leakage like abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation in the serous cavities like ascites, pleural effusion, mucosal bleeding, lethargy or restlessness, liver more than 2 centimeters palpable, and again rise in hematocrit with rapid decrease in platelet count. Severe dengue, they will have features of shock. There will be fluid accumulation with respiratory distress, and they can have features of severe bleeding and organ involvement. So LFTs, if they are done at this stage, the aminotransferase would be more than 1,000 units. They can also have neurological manifestations like impaired consciousness, and they can have multi-organ failure. So again, it's the same slide that I have said previously. So dengue with warning signs and severe dengue signs. So dengue with warning signs can go on to become severe dengue with features of plasma leakage, hemorrhage, and organ involvement. So clinically, they will have three phases, as I said in the first slide: febrile phase, critical phase, and recovery phase. So in the febrile phase, the incubation period is 2 to 7 days. So they can have high-grade fever. They have an erythematous rash, more like a measles kind of a small maculopapular erythematous rash. They have red eyes, sore throat, and older children might complain of headache, retroorbital pain, photophobia, myalgia, and arthralgia. And they might have mild, minor bleeding manifestations like petechia and mucosal bleeding. So you will see in a clinic or in an emergency department, most of the patients with viral infections or chikungunya, they can also present with similar manifestations. So you need to keep an eye and have a low threshold of suspecting a patient to have dengue if anybody presents with these symptoms. So tourniquet test, so you put a blood pressure cuff and you inflate the BP cuff midway between systolic and diastolic pressure for 5 minutes. So you inflate it and leave it for 5 minutes, and then when you take it off, after the cuff, there will be petechia 1 to 2 minutes after deflating the cuff. So presence of 10 or more new petechia in 1 square inch area is considered as a positive phase. So in febrile phase, you will see low white cells. You can have atypical lymphocytes. They might have mild thrombocytopenia. AST will be elevated, but it would be elevated more modestly, like roughly around 2 to 5 times the normal limits. So critical phase, it lasts 24 to 48 hours. Here the fever settles down, and they will have complications like they can have hepatitis, myocarditis, encephalitis, and severe bleeding. So critical phase, again, patient will have severe plasma leakage, which causes them to have shock. There will be fluid accumulation resulting in respiratory distress. They can have profuse bleeding. Again, multi-organ involvement. LFTs would be raised. Patients can have neurological involvement like seizures, encephalitis. Patients can have cardiac involvement like myocarditis and CCF. Dengue shock is the critical phase where patient will have massive leak, again hypovolemia, hypotension, shock, progressive organ involvement, and DIC. So if patient survives the critical phase, patient has been afebrile for 24 to 48 hours and has no complications, then they go on to a recovery phase where whatever the plasma leakage that has happened, the fluid tends to reabsorb, and the hemorrhage resolves, and the vital sign starts to stabilize. This phase lasts 2 to 4 days. So you can see the drop in hematocrit. So the other additional manifestations that can happen with dengue, as I've said before, respiratory distress, hepatitis. They can have encephalopathy, seizures, myocarditis, arrhythmias. They can have acute kidney injury, and they can also have retinal vasculitis. So diagnosis, you can do direct methods by picking up the virus. You can do a genome detection, or you can do NS1 antigen. In India, I think we do commonly NS1 antigen. Indirect methods is by checking the antibodies for dengue, serum IgG and IgM. So as I said before, primary infection, the viremia would be higher, and virus isolation and antigen would be higher. Whereas for patients with secondary infection, the antibody levels would be higher. So patients who had primary infection and who you suspect having secondary infection, it's preferable to do IgG and IgM antibodies. Whereas younger population who are suspected to have primary infection, it's preferable to do an NS1 antigen. So laboratory investigations, you do a CBP to look at the hematocrit, you look at the PCV, you look at the platelets. You can also do NS1 antigen, serum transaminases, because there will be a rise in LFTs. Creatinine, patients suspected of having an acute kidney injury, the renal profile will be deranged. Electrolytes, chest X-ray to if somebody is suspected to have a respiratory distress to rule out pleural effusion, and if you do ultrasound, you might find gallbladder edema. So differential diagnosis, as I said, lots of either viral hemorrhagic fevers present with similar symptoms, chikungunya, Zika virus infection, which is the recent virus that's been coming around of late, a lot of talk, malaria, typhoid fever, leptospirosis, viral hepatitis, rickettsial infection, sepsis due to bacteremia. They can have DIC, and again they can present with like similar like dengue. So management, not all patients need to be admitted. Some patients can be managed in outpatient basis if they are clinically well. So when you are managing them in outpatient basis, the main emphasis to parents should be they should know about the warning signs, like what they need to look into it, and ask the parents to make sure that the child gets adequate fluid intake up to 100 to 150 ml per kg per day. Fluids wise, they can get water, milk, buttermilk, juices, and use only paracetamol for pain or fever. Don't use anti-inflammatory drugs like Diabetic, because that again will cause the thrombocytopenia. It can worsen. And mainly educate the parents about what are the warning signs that the parents need to look for, and when they need to bring the child straight in if they notice any warning signs. So when you are managing patients in OPD, you need to manage them until they have gone beyond the deference, so the fever settles down and there are no complications. Till that time, patients need close medical supervision. So from the fluids point of view, they are getting admitted. The choice of fluids for dengue would be crystalloids, colloids, so normal saline. Colloids would be blood products, crystalloids for initial resuscitation. So colloids like blood products, FFP, you need to give for hypotensive shock, recurrent shock, and refractory shock. So patients with dengue with warning sign, fluid therapy is the mainstay of treatment because of their plasma leakage. So the choice of fluid would be 0.9% normal saline, DNS, or Ringer lactate. So initially, patients who present with warning signs, they should get a fluid volume of 5 to 7 ml per kg per hour for 1 to 2 hours, and then you repeat a CBP and see if the hematocrit is dropping down. If hematocrit is there is no further rise in hematocrit and patient is stable, you can taper down to 3 to 5 ml per kg per hour for over the next 2 to 4 hours, and then you can put on a maintenance of 2 to 3 ml per kg per hour. However, you need to make a frequent assessment by looking at their vital signs like pulse rate, that they are not tachycardic, pulse pressure, that there is no narrow pulse pressure, there is no hypotension, monitoring hematocrit, and also urine output. If at any stage you feel that the patient is having abnormal vital signs, or the hematocrit is rising, or the urine output is falling, then you need to escalate the fluid volume back to the higher volume to maintain the fluid deficit. So dengue with warning signs, hematocrit, if a patient remains hematocrit same or rises minimally, so you continue the same rate for 2 to 4 hours. However, if hematocrit is rising, then you need to step up the fluid. So in between, like you will be stepping up fluids, but you might need to give IV boluses to match up the fluid volume that has been lost. So you can give short-term boluses like 5 to 10 ml per kg intermittently. So uh, the main things you look and you know that critical phase is ending is by increased urine output. Patient is causing copious amounts of urine because the fluid is reabsorbed and the hematocrit is falling down. Initially, when patients are admitted, you need to monitor vitals 1 to 4 hourly. So yeah, if the patient is sick enough, you need to monitor vitals hourly. If patient is not sick, is stable, you can monitor vitals 2 to 4 hourly. Urine output should be measured 4 to 6 hours, and hematocrit should be measured every 6 to 12 hourly. So this is a classification. This is an algorithm that has been taken up from WHO. So for compensated shock, where the blood pressure is maintained but there are signs of reduced perfusion, is compensated. So you start fluid boluses, and if there is improvement, then you go on to the maintenance fluids, and based on the improvement you can wean down the IV fluids. However, if the patient is not improving and hematocrit is rising, you continue to make boluses, and you might have to give blood products as well if there is no improvement. This is again taken from WHO algorithm. This is for decompensated shock where the blood pressure is falling down, where you will be giving plenty of fluid boluses. The main thing is that sometimes a patient is hemodynamically unstable, but hematocrit is falling down. So think about whether the patient is having an internal bleeding. So falling hematocrit in a stable patient is different to a falling hematocrit in an unstable patient. So if you are suspecting internal bleeding, so look for hematocrit as well as vital signs. So monitoring vital signs, peripheral pulses. Clinically, you should be able to feel good peripheral pulses, which means that the patient is having adequate perfusion. The pulse pressure, the difference between the diastolic and systolic should be more than 20 mm mercury. Average urine output should be more than 0.5 ml per kg per hour, and hematocrit should be monitored before and after fluid bolus every 4 to and then again every 4 to 6 hours. So if you have given any bolus, then you need to check with hematocrit, and once the hematocrit is not rising significantly and patient is stable, then you can increase the frequency of doing the hematocrit every 4 to 6 hourly. So a patient is having a rising hematocrit but has a stable hemodynamic status and has good urine output, his vitals are stable. You don't need to give extra IV fluids, you just need to monitor them on the same rate and keep observing the high hematocrit. However, the hematocrit is rising and the vitals are abnormal, then you need to give further fluid boluses. Hematocrit is falling but vitals are unstable, then you think about internal bleeding and you need to give blood transfusion. And if hematocrit is falling but vitals are stable, then it means that the patient is recovering from the critical phase and you can consider stopping IV fluids. So hemorrhagic complications, minor bleeds, you don't need to give any blood products, you can give fluid resuscitation and replacement. Major bleeds, you can give packed red cells of 10 ml per kg or 20 ml per kg of fresh whole blood. So if patient is not responding and hematocrit is continue to rise, you can repeat the transfusion. If there is significant bleeding, you can give platelet transfusion. But ideally, if platelets counts are until they are not too low, you don't give platelet transfusions. You only treat the bleeding manifestations with packed red cells. If platelet counts are 60,000 or 70,000, you don't need to give transfusions. You don't give platelet transfusion unless it's less than 20,000. Again, there are risks with transfusion, so inappropriate use of transfusion itself is a risk for pulmonary edema. So respiratory distress can happen due to fluid overload during the recovery phase when the fluid gets reabsorbed absorbed, or you are giving inappropriate amount of fluids, like the patient is not critical but however are not showing warning signs. If patient getting is too much volume, or you are using hypotonic saline instead of an isotonic saline, which is normal saline, and sometimes too much cautiousness that you are continuing IV fluids even after the leakage has stopped and patient is improving, and you have given inappropriate transfusion of blood products, respiratory distress. So basically they will have tachypnea, they will have a shortness of breath, wheezing, they will have increased work of breathing like chest wall drawing, cough with pink frothy sputum, suspect pulmonary edema. So for them, treatment is like supportive treatment. So oxygen supplementation, you might have to go further up, like in the ventilatory support, like HFNC ventilatory support based on the clinical condition. Lasix, you can give 0.1 to 0.5 milligram per kg per dose once a day or twice a day in fluid overload patient, but be careful to use Lasix during the critical phase, because the patient is already having leakage, and if you give Lasix during that time, the patient might have further hypovolemia and can go into a severe shock. So this is given only unless you are pretty much sure that the patient is fluid overload. When you give diuretics, furosemide itself can cause hypokalemia, so you need to monitor the electrolytes and treat accordingly, and also monitor blood sugars and avoid hyperglycemia or hypoglycemia and dengue. Other adjuvant or supportive therapies that you use are vasopressors and inotropes. Future-wise, there have been a talk about steroids, immunoglobulins, and recombinant factor. However, there has been so far no data supporting the use of these. There has been a lot of research going on about dengue antiviral drugs and dengue vaccine, but nothing concrete. But hopefully in future, there are lots of research studies going on about dengue vaccine, and there are dengue antiviral drugs that are coming in the streamline. So hopefully we will be able to get top water. But at the moment, the treatment is mainly supportive, and for dengue, the main thing is fluid therapy during the critical phase. Watch for the signs and act on it at the right time. Saves the life. So patients can have complications and they can die if you are not picking up the warning signs at the right time, and you're not treating the patient accordingly. So you have to treat the patient, and you have to balance the vascular leakage with judicious amount of fluid. Thank you. Okay. Okay, fine. You guys, when I give you the topic, try to go through the topics, read it, and try to ask questions. Like, it's no point me just giving the talk. Like, it should be interactive way. So maybe from next time, like, try to go through it. I'm sure like one or two, there will be some doubts. So try to clarify it, like, so it's an important topic. So go through the topic first, read through it, and after the presentation, like, try to have some questions. So it would be more interactive.